I'm John Crosson, and I'm going to be completing a video on the concept of nephritic syndrome, which will be one of the presentations in the HD4 renal pathology section. Nephritic syndrome is defined in the following way. Patients with nephritic syndrome always have hematuria and often will have red blood cell casts in their urine. They almost always have hypertension, frequently will be azotemic, and also frequently will be oliguric. However, not all patients with nephritic syndrome will have all 5 of these manifestations. And usually the presence of hematuria and some degree of renal failure defines the broad concept of nephritic syndrome. So why do patients get nephritic syndrome? Well, they have glomerular inflammation with neutrophils and some mononuclear cells in their glomerular capillary lumens producing an inflammatory process. Therefore, this is an itis, meaning that there is an inflammation going on. The inflammation actually punches holes in the glomerular basement membrane, which allows red blood cells to escape through these holes into the urine. This is in marked contrast to nephrotic syndrome, which, as you know, is due to an abnormality in the filtration barrier, which leads to loss of massive amounts of protein in the urine, but usually few, if any, red cells. So nephritic and nephrotic syndrome are defined primarily by findings in the urinalysis. This is an important picture of a cut through a glomerulus, which points out the important morphologic findings in a glomerulus, which allow us to understand what goes on when the glomerulus becomes inflamed. You can see 4 capillary lumens in this picture. The one at the bottom has a red blood cell within the capillary lumen. On the right and on the left, there is a picture of the parietal epithelium, which lines Bowman's capsule. And between that parietal epithelium and the capillary loops resides the urinary space. The capillary loop itself is supported by 1 or 2 mesangial cells lying between several capillary loops and providing support for them. Each capillary loop is lined by a single endothelial cell, which is a very unique endothelial cell in that it has large holes or fenestrae within the endothelial cell surrounding the capillary lumen. This makes the endothelial cell of the glomerulus quite different than most other endothelial cells in the body, and maybe one reason why glomerular endothelial cells are so prone to being involved in pathologic disease processes. One of the most important parts of the glomerulus is the visceral epithelial cell, or the podocyte, which is pictured on the right-hand side of this particular diagram. Each podocyte puts out a number of foot processes which sit on top of the basement membrane of the capillary lumen and are very involved in the formation of the filtration barrier. Therefore, abnormalities in the podocyte is primarily what gives rise to patients with nephrotic syndrome. So let's take a look at the different pathologic lesions that can cause nephritic syndrome. One of the most important is post-infectious glomerulonephritis, also called by its morphologic name proliferative and exudative glomerulonephritis. This particular name describes exactly what's going on pathologically in this particular process. Antiglomerular basement membrane disease is a relatively unusual disease, but does produce nephritic syndrome. Systemic lupus erythematosus has a number of different processes which cause abnormalities in the glomerulus. The one that produces a diffuse proliferative process is characteristically associated with nephritic syndrome. IgA glomerulopathy is the most common glomerular disease in the world and generally is associated with nephritic syndrome. A very closely associated disease process, Hennock-Schönlein purpura, also has IgA deposited in the glomeruli and is often associated with nephrotic syndrome. And then finally, there are disease processes that produce a vasculitis that in turn results in glomerular changes and results in nephritic syndrome. Many of these are associated with anti-neutrophil cytoplasmic antibodies. There is an important disease process which is actually an overlap disease between nephritic and nephrotic syndrome because it is associated with glomerular inflammation and red cells and often red cell casts in the urine, but also it has a large amount of protein excretion usually. Therefore, this is classified as both a nephritic and a nephrotic syndrome. At the end of this particular video, I will talk a little bit about membranoproliferative glomerulonephritis. So let's take a look at post-infectious glomerulonephritis. As I said earlier, this is also called proliferative and exudative glomerulonephritis because there are large numbers of neutrophils within the capillary lumens, and this gives rise to endothelial swelling and proliferation. The exudation of the neutrophils and the endothelial proliferation basically fills up the capillary lumen and causes difficulty in the formation of urine. For this reason, it is associated with acute renal failure. We know that it is an immune complex process because IgG and complement are identified on the capillary loops, and these represent immune complexes. They have a very characteristic appearance by electron microscopy, which I will describe to you. This disease process follows beta hemolytic streptococcal infection, but many other bacterial infections and some viral infections can produce exactly the same picture pathologically and clinically. The important part of identifying this disease process is that it usually resolves spontaneously, particularly in younger patients. This is a drawing that shows what happens in the post-infectious glomerulonephritis. The drawing on the left-hand side of this slide represents a normal glomerular capillary with a single endothelial cell lining the lumen, the basement membrane, the podocyte, as I described earlier, sitting on top of the basement membrane in urinary space, and putting out foot processes which sit right on the top of the basement membrane. And the red cytoplasmic cell represents mesangial cells supporting the capillary lumen. On the right-hand drawing, you can see what happens when this capillary lumen becomes inflamed. There are two neutrophils within the capillary lumen. The endothelial cells are proliferating in that there is more than one endothelial cell, and the endothelial cells are swollen, thus filling up the capillary lumen. Mesangial cells are also proliferating, as shown in this particular diagram. The black arrow points to subepithelial humps, which are characteristic of post-infectious glomerulonephritis and represent immune complexes which are forming this particular process. The picture on the lower part of the slide also shows these humps, as does the electron micrograph on the right-hand side of the slide. So this is a picture of a glomerulus that is stained with Jones silver stain, which allows pictures of the basement membrane that stain black. You can see the capillary lumens are filled with cellular material, both endothelial cells and neutrophils. There are a few capillary lumens that are open, but the majority of them are obstructed by this cellular proliferation. This is a picture of an immunofluorescence study that shows the deposition of IgG and complement along the capillary loops, and also to some extent within mesangial cells. This is an electron micrograph of a very high power picture of a capillary wall with a blue arrow pointing to the subepithelial hump that was described. This type of hump is very characteristic of post-infectious glomerulonephritis and is almost diagnostic of that particular process. This is an electron-dense material which we know consists of the immune complexes that were talked about. Overlying this hump is the podocyte and the foot processes, which actually show effacement of the foot processes as a part of the inflammatory process. Underneath that hump is the glomerular basement membrane, and then way at the bottom of the picture are parts of a swollen endothelial cell. Up to the top of the picture represents the urinary space above the blue arrow. Lupus erythematosus glomerulonephritis class 4 is also an immune complex disease process which results in marked proliferation of endothelial cells and exudation of neutrophils. We know that this is an immune complex disease which is due to the deposition of anti-double-stranded DNA and double-stranded DNA in the glomerular capillary lumens in a very characteristic pattern. The immune complexes consist of IgG, IgA, complement, C3, complement, C1q, and IgM. This is called a full house type of immunofluorescent pattern. Characteristically, patients with active lupus glomerulonephritis have low serum C3 levels. These patients, as you know, form autoantibodies to many different antigens and produce many different anti-nuclear antibodies, particularly anti-double-stranded DNA. Patients with lupus often will produce another antibody called anti-SM antibody, which is essentially diagnostic of lupus erythematosus. Patients with class 4 lupus glomerulonephritis will have more than 50% of their glomeruli involved, and each glomerulus will show proliferation involving more than 50% of the glomerular tuft. This is a lower power picture of a patient with very proliferative lupus glomerulonephritis involving all three of the glomeruli in this particular picture. The glomeruli have a lot of eosinophilic material, some of which actually fill capillary lumens, which represent the so-called hyaline thrombus of lupus nephritis. As you can see, very few open capillary lumens are present in these pictures, and so this is a class 4 very proliferative and exudative lupus glomerulonephritis. This is another picture of a patient with class 4 lupus glomerulonephritis, which shows more characteristic thickening of glomerular capillary walls. Almost all of the capillary walls are thickened, and this is due to subendothelial deposition of immune complexes, which I will show you on the next slide. This has been called the wire loop picture of lupus nephritis. This is a Jones silver stain of a couple of capillary loops in a patient with lupus glomerulonephritis. The capillary loop on the right-hand side of the picture shows a large amount of red staining material or eosinophilic material within the capillary lumen underneath the glomerular basement membrane. This is called a subendothelial deposit and is responsible for the picture of wire loop that is seen frequently in lupus. On the left-hand side, you see a capillary lumen that is filled with red staining material. This represents the so-called hyaline thrombus of lupus nephritis. This is a picture of an electron micrograph showing 3 capillary loops, and each of the loops has a blue arrow pointing to the subendothelial deposits that are characteristic of lupus nephritis. In the central capillary loop, you can see the blue arrow pointing to the subendothelial deposits, and then just adjacent to the subendothelial deposits is a swollen endothelial cell producing a very narrow lumen. Below the capillary loops is the mesangium, which contains a large amount of electron-dense material as well. We know that this electron-dense material consists of antibody to double-stranded DNA and to double-stranded DNA. Antiglomerular basement membrane disease, as I said earlier, is a relatively rare disease but produces a very severe glomerulonephritis with very severe renal failure, often leading to loss of renal function requiring renal replacement therapy. We know that this is due to a spontaneous development of an antibody to a glomerular basement membrane antigen. This antigen is the alpha-3 chain of type 4 collagen, actually the non-collagenous portion of type 4 collagen. This antibody fixes complement and damages the glomerular basement membrane, producing holes in the glomerular basement membrane which allow red cells to escape into the urine. Many of these glomeruli will show evidence of segmental necrosis that I will show you in a minute. This results in large molecular weight proteins getting into the urinary space, and the large molecular weight proteins stimulate the formation of so-called crescents, which actually represent proliferation of primarily the parietal epithelial cells admixed with some mononuclear cells. And the crescent formation is the main reason why the glomerulus is not forming urine, because of compression of the capillary lumens from the outside. We know that this particular antibody will cross-react with an epitope that is present in the basement membrane of pulmonary vessels, and patients with antiglomerular basement membrane disease will often have marked bleeding from their lungs or hemoptysis. And this actually can lead to death in these patients. This is a picture of a glomerulus of a patient who has antiglomerular basement membrane disease. In the center of this particular picture, you can see areas of red staining material which represent necrosis of that portion of the glomerular tuft. On the right-hand side of the picture, you can see a number of capillary lumens that are perfectly normal and are uninvolved. Therefore, this is a segmental type of process, and it's a necrotizing process because portions of the glomerular tuft are undergoing necrosis. This is due to, as I said earlier, an antibody that forms against an antigen within the glomerular basement membrane. When stained with antibody to human IgG, this gives a very linear diagnostic appearance, as you can see in this particular photomicrograph. IgA glomerulopathy, or IgA glomerulonephritis, is the most common glomerular disease in the world. It is particularly common in portions of the Asian countries, and in some countries represents over 50% of the glomerular disease seen in these countries. This is due to deposition of IgA1 in the glomerular mesangium. There is usually C3 complement and IgG deposited along with the IgA. We know that the IgA in these patients is abnormal and basically has less galactose in the IgA than a normal IgA molecule. Therefore, this abnormally galactosed IgA, it becomes immunogenic, and patients make IgG autoantibodies to the abnormal IgA. Therefore, this is an immune complex autoimmune disease process. There are receptors in the mesangial areas that can bind to this abnormal IgA, so not only is it a circulating immune complex disease, but it also results in abnormal IgA being deposited in the mesangium without there being any IgG in the complex. This deposition of IgA in the mesangium results in a cytokine release from a number of different sources. In particular, the platelet-derived growth factor that is released results in proliferation of mesangial cells and increase in mesangial matrix. This characteristically will come on 1 to 2 days after an upper respiratory tract infection, probably because IgA is the common immunoglobulin found in the respiratory tract, and an upper respiratory infection stimulates the release of this abnormal IgA into the circulation. This is a picture of a patient with IgA glomerulopathy with very marked proliferation and increase in mesangial matrix. Almost all of the capillary lumens in this particular situation are patent. However, these patients characteristically have quite significant hematuria, and this is often the presenting manifestation of this disease process. This is an immunofluorescent picture of a patient with IgA nephropathy showing extensive deposition of IgA in the mesangial areas. 1 or 2 capillary loops show also evidence of the IgA in the capillary loops themselves. This is an electron micrograph showing electron-dense deposits in the mesangial areas. The blue arrow points to a large electron-dense deposit which contains the abnormal IgA. This electron-dense deposit is adjacent to the basement membrane which surrounds the mesangium, and this is a characteristic location for the immune complexes in IgA glomerulopathy. So this particular picture would be very suggestive of IgA glomerulopathy. The last main disease we're going to consider is paucoimmune segmental necrotizing glomerulonephritis, often associated with the presence of circulating anti-neutrophil cytoplasmic antibodies. As with anti-glomerular basement membrane disease, this disease process also produces segmental glomerular necrosis and crescents. Two forms of disease processes can do this, so-called microscopic polyangiitis and granulomatosis with polyangiitis. The anti-neutrophil cytoplasmic antibodies can have 2 different patterns, which I will show you in just a minute. One is a P-ANCA pattern produced by fluorescence of material around the nucleus, and the other pattern is a C-ANCA pattern which produces fluorescence throughout the entire cytoplasm. The P-ANCA pattern primarily is due to the presence of anti-myeloperoxidase, while the C-ANCA pattern primarily is due to the presence of anti-proteinase 3. This particular study, which can be done on serum, is of diagnostic and etiologic importance in evaluating patients, and produces basically a segmental vasculitis. This is a picture of a glomerulus showing, again, segmental necrotizing glomerulonephritis. The light microscopic picture is identical to that seen by patients, seen in patients with antiglomerular basement membrane disease. So immunofluorescence studies are important in separating these disease processes. On the left-hand side, you can see areas of necrosis of capillary loops. And on the right-hand side, there is a single capillary loop that shows necrosis of the basement membrane with the formation of a large number of cells outside of that particular capillary loop. This is producing a characteristic appearance of a crescent. This is a picture showing both the P ANCA pattern and the C ANCA pattern. These studies are done by taking ethanol-fixed neutrophils, overlying them with the patient's serum, and then reacting those neutrophils with fluorescein-labeled antibody primarily to human IgG. The left-hand pattern is a pattern for the P ANCA pattern, which is due primarily to anti-myeloperoxidase. The right-hand pattern is a C ANCA pattern, which is due primarily to antibodies to proteinase 3. What are the diagnostic relationships between these anti-cytoplasmic antibodies? Well, 82 to 94% of both granulomatosis with polyangiitis or microscopic polyangiitis have anti-neutrophil cytoplasmic antibodies. Granulomatosis with polyangiitis used to be called Wegener's syndrome, so occasionally you will see that in the literature. The GPA is mostly associated with the C ANCA pattern due to presence of antiproteinase 3, while the MPA is mostly due to the P ANCA pattern due to the presence of anti-myeloperoxidase. It's important to know that up to 10% of patients with either of these two types of polyangiitis are negative for anti-cytoplasmic antibodies, so the lack of these antibodies does not exclude these disease processes. And finally, about 20% of these patients will have the other antibody rather than the one that's characteristically associated with their disease process. So the anti-neutrophil cytoplasmic antibodies cannot be used exclusively for diagnostic purposes. It's also important to know that maybe up to 40% of patients with anti-glomerular basement membrane antibody disease will also have positive anti-neutrophil cytoplasmic antibodies. So the presence of these antibodies does not exclude the presence of anti-glomerular basement membrane disease, which has to be diagnosed using immunofluorescence on a kidney biopsy. Now let's take a look at the membranoproliferative pattern of injury, which is a new terminology that has replaced the old terminology of membranoproliferative glomerulonephritis. The reason it has replaced that is that there are many, many conditions that can give rise to this pattern of injury, and therefore this is the terminology that is currently used. Frequently there is immunoglobulin, either IgG and or IgM deposited in the subendothelial space along with C3 complement. There is then new basement membrane which forms on the luminal side of the capillary loop. This produces splitting or duplication or trantracking of the glomerular basement membrane. It frequently implies an infectious etiology, and if only complement is deposited rather than immunoglobulins, this then is now called C3 glomerulopathy. This slide represents some of the causes of membranoproliferative pattern of injury. In particular, patients with this pattern of injury should be investigated carefully for the presence of hepatitis C infection, because there's a strong association between the presence of hepatitis C infection and this particular type of glomerular disease. Patients with endocarditis can have this pattern. Patients with HIV infection. Mixed cryoglobulinemia will characteristically produce this disease process. Patients with rheumatoid arthritis as well as systemic lupus erythematosus will have frequently this pattern of injury. Monoclonal gammopathies are associated with this disease process, and many different cancers have been associated with the membranoproliferative pattern of injury. This is an H&E picture of a patient with membranoproliferative pattern of injury. And this is characterized by a lobular appearance to the glomerular tuft with thickening of glomerular capillary loops due to subendothelial deposits. The green arrows on the left-hand side of the picture show the presence of a proliferation of parietal epithelial cells producing a very small crescent. As you can see, this glomerular tuft is markedly hypercellular, and many of the capillary lumens are obliterated with this increase in cellularity. This is a picture of a single glomerular capillary loop, which demonstrates characteristically what goes on in the membranoproliferative pattern of injury. The green arrows point to the original basement membrane of that capillary loop. The red arrow points to a cell that is interposing itself between the original basement membrane and the endothelial cell of that capillary loop. This is likely a mesangial cell which is interposing itself. And the blue arrows represent the new basement membrane that is being formed as a part of this interposition of the mesangial cell, thus producing splitting or duplication of this capillary loop. This is a characteristic finding of membranoproliferative pattern of injury, and there will often be immunoglobulin and complement in the subendothelial space, and frequently electron-dense deposits will also be found in the subendothelial space. So this disease process, membranoproliferative pattern of injury, can produce either nephritic syndrome or nephrotic syndrome or both, and therefore it is usually thought of as a nephritic-nephrotic type of syndrome. So this is the end of this video, and this video has covered the majority of conditions that give rise to nephritic syndrome.